Good evening, everyone. Welcome to this evening's webinar update on Zika, clinical and ultrasound issues, presented by Dr. Lawrence Platt. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. At the conclusion of this activity, participants will understand the origin of the virus and recognize signs and symptoms of the disease. Participants will also be able to understand ultrasound signs of Zika and know how to advise pregnant patients regarding risks of travel to Zika areas. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Platt's disclosure for this activity is listed. Kathy Minton has no disclosures. At the conclusion of this webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During tonight's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time he will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now, we're pleased to present Dr. Lawrence Platt.
Can you hear me, Kathy?
Yes, thank you, Dr. Platt. I hear you just fine.
Okay. First of all, good evening to everyone, and thank you for joining us on this evening. Today, I hope to be able to share with you some of the current insights into Zika and the effect that it's had on many of our patients. It certainly has captured the world and the interest because of its teratogenic and catastrophic effects on the family. I will share with you some of the current clinical observations as well as the ultrasound findings that have been recognized through the experiences of centers in Brazil, Rio de Janeiro, California, New York, Puerto Rico, and throughout the world of interest in the Zika virus. I will turn off the camera now and put you straightly to the presentation so that you'll be able to follow it quite closely without having to watch me as I present. But when we come back to the questions at the end, we'll put back the direct relationship between me as the speaker and you as the questionnaire that you may have. And I'm glad to answer any questions that you may have. Okay. I think Kathy has already alluded to disclosures. I add a couple things to the information. Is I did serve as advisor to the World Health Organization, where they did reimburse my travel to Geneva, in developing their plans and statements that have come out in March of last year. In addition, a number of us serve with the USA as an external consultant to their interest in developing a way to assess Zika in some of the Latin American countries. And because I will share you some information through our ISWAG, the International Society of Ultrasound, and GYN, and the AIUM, I list that I have been president of both of those societies. When we talk about Zika, we're talking about the Aedes aegypti mosquito and the virus. It ends up being an important mosquito which has a vector in urban areas, and it really is something related to our homes. It could happen anywhere for that matter. In fact, these mosquitoes are around the country. They're certainly in California. Fortunately, they're not affected by the Zika virus, which has caused all this problem, which we'll see tonight. In addition, there are other Aedes types of mosquitoes. Albopictus is another one. These are found both indoors and outdoors, and they're in different habitats than those that we see generally in the United States. But I think you can see on the map that the Aedes aegypti mosquito and virus with the Zika is found almost the same areas, albeit this may have a little bit more extension in the other parts of the country. Now, what about further north? You know, the big question is, does it only stay in the warm areas? Is that where it is? And you're going to hear me say throughout the presentation, indeed, the sea level is very important where these mosquitoes go, where the virus can be harbored in. It does tend to be in warmer climates, and that's why, not surprising, as you've heard, it's occurred in Florida, it's occurred in Texas, but there's some population persistence of this mosquito even in Washington, D.C. We're in the area of the AAUM headquarters. But typically it doesn't thrive in these areas because of the temperature that is there. So, but you don't have to think that you're immune if you live in those countries, because as you'll see, there's other ways to obtain this disease. About 20% of people infected with Zika virus become symptomatic. This is really important. It means 80% don't, and they may be affected, and that's why when we ask our patients, which is one of the most important things I can relate to everyone on a seminar, is that you got to ask your patients, have they traveled anywhere? Because if they were infected or bit without having symptoms, it doesn't mean that they're immune, that they didn't get the disease. They can get it. Typically, the symptoms, which are mild in the beginning, develop within 2 weeks of the exposure, and it lasts several days to a week along the lines that we know about, and become very important to what we're doing. If you look at the effect and how to protect yourself and how to protect your family from getting this disease, remember the mosquito can be in an area that's endemic to the disease, but you don't have to be there. Someone could have traveled there. So we know that, for example, if the mosquito gets infected itself with the virus and then it affects someone else, okay, the person who gets the bite could be infected, certainly that's there. They have other ways to transmit it, as you've heard. It certainly can transmit it through sex. It can transmit it through blood transfusions. We'll talk about that a little bit later as well. And a mosquito itself can bite you, who may be infected, and obtain the Zika virus itself. So that transmission cycle is very complex, as you can recognize on the CDC website, which I'm going to refer to many times in this presentation, and encourage all of you to go to the CDC website to obtain a lot more information on the Zika virus. This is the picture that captured our concern. A baby born with small head, and the world thought that it was only microcephaly, which you and I know is not the case, and we'll go over those things, but this is the one that struck the families the most. The baby that develops poorly, the baby with the small head, the baby that can't sit up for a while or a long time or ever because of the severe effects of what microcephaly and central nervous system damage, which is probably a key way to think about it, happens. To date, as of January of last year, and I'm going to show you many more cases, as you will see an update through last week, over 4,700 cases of suspected microcephaly have been attributed to Zika in Brazil alone during that period of time. In Brazil, which allowed us, Adrienne Malley, who first came and identified the disease because what she saw in her own clinic population, probably the one that brought the alert to the public health officials, brought the alert to the ultrasound community, sent information to colleagues around the world, individuals like Gustavo Malinger, who, if you attend the annual meeting in 2 weeks in Orlando at the AUM, he will be presenting several presentations on the Zika virus himself and his experience in looking at all of these findings, both in ultrasound and even MR. There's no question that this is what attributed to our greater need to understand the pathophysiology of this disease. As of January this year, and I'm going to have a map that actually shows you even more recently this was updated January 26th, and it is forever being updated by the CDC. Another reason I encourage all of you listeners who have the interest in Zika to go to the CDC websites for this information that on a weekly basis, usually on Wednesday, they update all the information, but you can see the changes that have happened to the migration of the Zika virus. Let me remind you the fact that probably is a trivial fact, but of great importance, is this mosquito is not flying from Florida to Los Angeles. This mosquito is not flying from Central America or South America to the United States. In its lifetime, a mosquito may fly anywhere from maybe a half a mile to a mile. There isn't the distance. So it gets transmitted through its other vectors that we talked about, that's through water that may be sitting dormant for 6 months at a time. Two major lineages of Zika virus occur, the African and the Asian. African lineage only reported in Africa and most recently identified in sequences analysis of 7 cases in Guinea-Bissau, and Asian consists of strains from Asia, Western Pacific, Americas, and Cabo Verde. Let us remember that these have been around a long time. First found in French Polynesia, where in the 50s that they identified cases of Zika. It was only recently that we really saw the great exposure in Brazil that captured our strong interest around the world because of the catastrophic endemic and epidemic that occurred. We know that neurologic complications have been linked only to the post-2007 strains of the Asian lineage. As I said, in French Polynesia in 2013, and in the U.S., Cabo Verde as well. Congenital syndromes associated with Zika virus infection occurs. Everyone thought it was microcephaly, but indeed, if you think about rubella, congenital rubella syndrome, we too believe there is a congenital Zika syndrome, and probably a better way for us to think about it. Because as you will see, and I will share with you the ultrasound images of the findings, whether it's in the brain, whether it's in the limbs, and even the eyes may occur, there's no question that there's congenital syndrome identified in over 21 cases, and yet 4 of the 21 countries reported microcephalic babies from recently traveled to one of these affected areas. Remember that. Going to these areas is critical. So again, I will repeat, all of those of you who see patients should have signs up in your office saying, have you traveled anywhere? And find out where they are and see if they've gone to an endemic area. You'll see what you need to do as we proceed. So the spectrum of teratogenic effects is represented by NICHD, whether CDC, whether it's the WHO, whether it's SMFM, whether it's AIUM, is IUGR, growth-restricted babies. Miscarriages have been reported and stillbirths have been reported increased in those that have been affected. It can affect the eye with cataracts and chorioretinitis, and I'll show some examples of that. And in the brain, it's not just microcephaly that you see here, it's what goes along with it, because you could actually have hydrocephaly and the head looks almost normal. So we know that there are many more things that occur. There's been examples of problems with the corpus callosum, the pons, the cerebellar vermis. There's been neuromigrational disorders, lissencephaly, and disrupted processes that you can see to the right on this picture as well. And something striking, something that we should be looking for, is the cerebral calcifications that one can see that are often the only subtle find that you may see in these cases. It's very important that we pay attention to that and brain asymmetry that may be there. These babies have neurologic compromise, they have hypertonia, they have swallowing problems, and again, as I said, there are other findings, including arthrogryposis, which are joint contractures, as you know, and they have neurodevelopmental problems with seizures. In a study from Brazil, Brazil is the author in the New England Journal, you can just see selectively different microcephalic, cerebral calcifications, megacisterna magnum, a variety of central nervous system disorders that are there that are very, very important. So 29% have fetal anomalies, 17% have the microcephaly that you see here, or atrophy of the head with calcifications. So know that no one case necessarily has to look exactly like the other, as we know for all other things. I might point out a very concerning issue as well, is when does this most affect the fetus? Brazil, in their work in the New England Journal of Medicine last year, showed that it doesn't matter when the virus affects the pregnant woman. This is the Rio de Janeiro work, who our colleagues at UCLA are working with. Very clearly, it can affect at any time in pregnancy. And so, sure, the earlier its effect in the fetus, the earlier it attacks the mother, the earlier it's going to affect the fetus, and more likely you'll see more severe findings. But we really don't know, and that's part of the NICHD's work today, is following these babies post-term, post-delivery, and looking to see if they were affected in the third trimester, what happens to the development of these babies. It's going to take a while to understand the whole pathophysiology. But don't be fooled by, all right, it didn't happen in the first trimester. It can happen in any trimester. We also know that the viremia persists over 5 weeks. And when we start testing, we need to know when should we test these fetus, the mothers, from exposure, and when is it too late? When should we do the PCR for the RNA virus, or when should we do IgM studies? And we'll look at that in a few moments, but very clearly, as a rule, earlier, the first 2 weeks of exposure is the PCR for the virus itself. The other is the IgM after the 2 weeks, but not beyond usually 2 to 3 months where we test these babies. I would also point out that in many of these endemic areas, in many of these areas, certainly in Brazil and in Rio de Janeiro and Central America, the association with other viruses related, flavoviruses, dengue virus and chikungunya, can also have some cross-reactivity. So it's going to be important to rule out those, as we see in these cases that I demonstrate here. The prolonged detection of Zika virus in the RNA pregnant is something of great interest to the CDC, and they've developed a registry of pregnancy effects. So patients who are identified, certainly one should notify the public health departments in their city and their state. We work very closely with Los Angeles County. My associate Neil Silverman is very prominent in working with the local health department, the state health department, American Academy of Pediatrics today as well, and even the CDC in the infectious disease area of our interest. But very clearly, a strong support of the Zika registry is going to be very important for our full understanding of prevention of the disease, and we'll get into that a little bit later. As you can see, they've done studies in monkeys, and some preliminary data certainly shows that the virus, when exposed in a monkey, can persist a week or two, and I think that's going to be very important for our understanding. Now, if we just wait for microcephaly as the marker, it's very specific, clearly, and as most people know, it's very difficult to make this diagnosis in utero. We know that in studies that we did in the early 80s, looking at maternal PKU and their offsprings, where microcephaly is a great risk, especially in uncontrolled phenylketonuria, it was very difficult to make the diagnosis early on, and sometimes delayed after the 26 or 28 weeks of pregnancy in those cases. And that's work that Roger Linke and myself did back then to try to identify earlier, and we just couldn't do it earlier than that. And it really has to do with the head size. And very clearly, it's defined as head circumference of less than the third percentile. But I can assure you, each of us, on a regular basis, see patients that have small heads that don't prove necessarily to be microcephaly, particularly if it's just less than the third percentile. And we look for really greater than 3 standard deviations and maybe 5 standard deviations in utero to make this diagnosis. It's simply an early trigger. Adriano Mello, as I said, was the first to publish the early cases and recognized confirming it from amniotic fluid, which they had brain atrophy as well. I think it's real clear that this, if we wait for microcephaly, we're probably waiting too long to make this diagnosis. And if, in fact, over the course of time, we find some treatment for those patients who will not terminate a pregnancy, obviously early diagnosis and early treatment become extremely important for us. So if we look at what societies have done, the American College of OB/GYN, along with Society of Maternal Fetal Medicine, have given a number of practice advisories, and I list that here. And again, these slides are certainly available for you later on as it's being reported. These are some things that have become, I think, of interest. But the most important thing is they keep getting updated on a regular basis. Societies such as the Society of Maternal Fetal Medicine made some statements on microcephaly, very much what I said, but isolated fetal microcephaly should be defined as greater than, not equal, greater than 3 standard deviations below the mean. And the pathologic diagnosis does not usually occur until greater than 5 standard deviations, as I addressed earlier. So, if that's the case, what should you do? I think if you look at CMV as the model, it really needs at least 6 weeks post-exposure to see any possible impact on ultrasound. And really, as you know, the current guidelines are not prescriptive. If the serology is negative and reasonably timed post-exposure ultrasound is normal, then routine surveillance of these patients are going to be very appropriate for us to do. I don't think we have to look every 2 weeks because we're not going to find the difference. So when one has traveled to an area of Zika virus transmission, what should you do? Well, the first is you want to test for Zika virus infection. And that's symptomatic or not if they've traveled to that area. Remember, let's go back to probably the first 2 slides. Only about 20% of individuals are going to be symptomatic, man or woman, pregnant or not pregnant. So I think that's very important. And if that's the case, if we start studying that by PCR techniques, if it's positive or inconclusive for virus infection, you should consider, obviously, fetal ultrasounds to make the diagnosis, and even consider an amniocentesis to identify and isolate the virus from the amniotic fluid. On the other hand, if it was negative for the Zika virus infection from our studies, fetal ultrasound seems to be reasonable as well because of our concerns for maybe we didn't identify it, and if there are other things over time that we can see, including development of growth of the fetal head circumference and intracranial calcifications, I think obviously that might point to the right side here where this infection may affect the baby. And if that's the case at 20 weeks, 24 weeks, 26 weeks, still doing an amniocentesis to isolate the infection may be there. On the other hand, going on the negative case, if there is no suspicion of growth changes, if there's no suspicion of calcifications in the central nervous system, if there's no suspicions of any structural changes that have been associated with the Zika virus, then certainly routine care is very reasonable. Now for the next portion, I'm going to share with you some of the work that's been contributed in a seminar that we did with Elon Timortridge and Gustavo Malinger and Mauricio Herrera, both in English and in Spanish, for the congenital Zika virus syndrome. And we're going to go through some of these findings and show you both in still images and video clips the kinds of things that you can see in the ultrasound findings, including volume reduction or brain atrophy, which I don't know about you, but I can tell for me it's often very difficult to make that assessment when you're looking at the size of the head. We don't typically measure volume of the head. I think it's more the MR individuals who like to suggest maybe the brain looks a little small. We hardly report that in ultrasound. I suspect if there's a lot of subarachnoid space compressing the brain, we might be suspicious of it. Or if there's lissencephaly, we might be suspicious of it. But typically we don't. So, but we got to think about that, particularly in the congenital Zika virus syndrome, as we talk about. So we talked about the microcephalic, calcifications, subcortical, cortical, periventricular, cerebral, ocular, all over the place, not in one spot. It can be anywhere. And if we're careful and we're looking at high-resolution systems, both transvaginally with through the transfontanelle with the medium approach that's been described many times over by Timor and others, and there's abnormal gyration and sulsation, then might suspect the problem. And the rest, as you see here, ventriculomegaly, colossal dysgenesis, destructive lesions, and all the others that are listed, certainly we need to think about. So I asked Gustavo last year, before the presentation, if we're trying to teach how to get the best out of an ultrasound in the central nervous system, And you see the question is real simple. What are the correct planes to evaluate CNS? And his answers are here. I'm not sure that I can answer this question due to perceived difficulty in performing the examination in these patients due to the small size of the fontanelles and sutures. So that's not a knee-jerk response. That's a real-life response in someone that's had experience in trying to make this diagnosis. 2 says, ideally you need to obtain 3 axial planes as described in the ISWA guidelines, plus 4 coronals and 3 to 5 sagittals. It will be extremely difficult, but not impossible, to miss a significant finding this way. Personally, and according to my own experience, and after observing my own team missing findings in patients with CMV, I think the more important that the planes is to know exactly what to look for and where to find it. And that is what the next ultrasound images that I'm going to share with you that hopefully will be beneficial to you if you've asked to see a patient who's positive. Microcephaly. Certainly we all can measure the head. Certainly we all could recognize what the shape looks like on the fontanelle of the forehead, the frontal bones. We can look at suture lines and see if the sutures are prematurely closed and the chance that there be microcephalic that's there. But here, these are small heads and small head sizes that you can see here. This is a head circumference that's less than the first percentile. These are things that we need to think about and recognize in a 28-week fetus and a 29-week fetus, yet alone in the reconstructed head that you see here. Another example, another shape change that occurs if you're looking at it in these babies that catastrophically have microcephaly. They often will have large subarachnoid spaces, and that will compress, and that's where you get some of the brain atrophy that we talk about. And here's some of those examples that you can see here. Here's a 28-week fetus with large subarachnoid fluid, same in the middle one, and then certainly the one on the right, you can see that very clearly showing those changes that are there. Here's a video clip of brain involvement, and I go through that, and I'll go over it again once more, but strikingly there should be 2 things that you should all be able to recognize amongst the largest things that are strikingly here besides the posterior area that you may see here. You see ventriculomegaly, and you also see the calcifications in the brain that are there. Another case of ventriculomegaly and the calcifications that we're clearly seeing here and all areas of the brain. There you go there as well in these cases. So looking carefully, looking for the subtle changes to calcifications is another clue that may be the first ones that you see before you, and they're right there as well, before you see the ventriculomegaly. It doesn't necessarily come one after the other or proceed accordingly. So when we look at the brain involvement and we look at these babies look like, and here you can actually see the arthrogryposis, you see the way the hands are almost one over the other without very little movement, without even seeing it. This is a picture of the month in the ultrasound in OBGYN, and you can see the changes that how the head shape is a flattened head shape, irregular brain changes that are there. And these are the things that we look for in the skull of babies that certainly have abnormalities. And you can see the fontanelles are small, some of them are prematurely closed, and these are models that have made a difference. As I said, the calcifications can be anywhere in the brain, subcortical, cortical, periventricular. Here's some more examples, both clips that you can see here. You see the calcifications on the top left, calcifications, and even a little bit of ventriculomegaly here, calcifications, more calcifications everywhere within the brain, and changes that go along with it that are there that you can see strikingly. You can see it transabdominally as well. You know, obviously, as I said, if you have a vertex presentation, you're going to see see it through a transfontanelle approach transvaginally much better. But clearly, if it's a breech presentation and it's excuse me, and its head is not engaged, transabdominal, you can see the same very changes that we talked about just a moment ago. Here's calcifications in transvaginal ultrasound, just to show you the remarkable differences that you see in the image quality that are there. Excuse me. Here's another example, transvaginal, seeing the changes in the ventricular system, as well as some of the calcifications that you can perceive right there on the image that we can see very candidly. More examples of transvaginal ultrasound with the vasculitis. These are probably calcifications in vessels within the brain. I don't have color turned on here, but it's the most likely reason for some of these calcifications was perhaps some clotting mechanism that occurs after the vasculitis and an infectious process that's taken place, and it demonstrates it secondarily from the clot to a calcification that has then a secondary effect to affect the brain, as you can see here. When we looking at this vasculitis, you can see the changes that are there with the higher power magnification and the sutures of the vessels where they have white cells that are coming in there. As you can see, it's circled here, and it's showed up here in the vessels that you have in this area, characterized by the macrophages and the white cells that are sitting in the area of the vessels within the brain, as we saw these calcifications on ultrasound. Obviously, this is post-mortem examinations of these babies that are there. Here's another showing you medullary calcifications, as you can see, and again, post-mortem examination of these babies that are there and the calcifications that occur all over. Now, when we start looking at thinking about what have I seen before in other examples of viruses, and CMV is certainly one of them, you probably remember that there were cysts within the ventricular system. And here's 4 examples of cysts. And I'm not going to point out just yet, but just in a moment, that these may be from a Zika case. It may be from a CMV case. They look very similar. And I think those are the things you can think about. So here you see 3 cases of Zika from South America versus an example from Gustavo Malinger's work in Tel Aviv. So you can see the changes that are dramatically there in terms of what we see within the brain themselves. Here's more cysts within the ventricular system. Anytime you see cystic changes within, and I don't mean a choroid plexus cyst, I mean truly a cyst within the ventricular system. This is not part of the choroid complex. You need to think about congenital virus. You need to think about the fact that it could be a CMV, as you can see up here in this area, or it could be, if they were exposed to Zika, it certainly could be Zika. Abnormal gyrations, pulsations take place. Here's another example, both on ultrasound and MR. You see sort of a brain atrophy with a lot of fluid around the brain here. You can see it clearly in ultrasound the same way with delayed sulsations, very smooth brain. No one would call this normal at all. Developing a lissencephaly that you can see here as well. More examples of the same from Brazil. Irregular ventricular walls, changes that go along with poor development of the central nervous system. Schizencephaly can take place too, where you see there's sort of a ablation of part of the brain. You're missing part of the brain, probably infarcted. And this is another example from Colombia where they had a case of Zika that had a schizencephaly. Here's more dramatic cases that you can see on the right side of these images. Abnormal cortical development, as we talked about as well. Here's a post-mortem example of that baby, and you can see how the brain is smooth, it's small, it doesn't fill the whole brain, and atrophy has taken place, as you can see there. We talked about ventriculomegaly. We'll just show some more examples both on ultrasound and MR. On your left, you see the ultrasound very nicely. I don't think you have to measure this in the sense to recognize you got a problem, particularly if you have a history of exposure. And on the right, dramatic effects that you can see in MR. You don't need MR to make this diagnosis. I think it's really clear when you have those findings. More examples of ventriculomegaly, as you can see very nicely here. More examples, and again, here you see the cystic changes that you saw earlier as well. So it's a double insult that's occurred. There's an infectious process that caused an effect to the change of the brain and brain development that's there along the way. Colossal dysgenesis, you may see changes of the corpus callosum. You can see complete agenesis. You can see partial agenesis. That makes the diagnosis of that alone very difficult, but here you can see whether it's the beginning, the end of the corpus callosum that becomes very important. Destructive lesions, you saw some of the destructive lesions you saw before. With right here again, this schizencephaly very clearly catastrophic, not much can be done with these babies. And again, depending upon when you see it, options of termination, should that be available. As you know, in some of the countries that have the worst case breakout, termination for these women are not possible, and the long-term care is certainly going to be significant. There also could be cerebellar or midbrain involvement, and you can see here changes that occur posterior fossa, dramatic changes in the posterior fossa here. It's just this enlarged cisterna magnum. The vermis seems to be present in this case, but they have a megacisterna magnum. You got to make sure you can distinguish that, but there may be other consequences of the findings. And again, on the right, the same types of changes that are seen posteriorly. More examples of cases that have been submitted for our review showing posterior fossa abnormalities in the cerebellum and changes that go along with Zika. MRI changes again. Again, our ultrasound first certainly speaks for itself in OB, and certainly many of the findings that you're seeing are so accentuated that the ultrasound should have been able to make these diagnoses for yourself. There are also ocular changes. Here you can see actually a cataract form. Here's changes in MR that you can see in the eyes. There's sort of a graying and opacity that you can almost see on the ultrasound as well of these babies. Essentially, cardiovascular changes as well, and there's a big question of whether EIFs should be suspected in cases that are there. We recently submitted a paper that I did identify some cases that have EIFs that may be part of the Zika syndrome, but as you and I know, we see so much of the EIF, and isolated EIF is not a reason to suspect Zika unless there's been direct exposure and are things about it. But there certainly can be changes along the wall that go along with it. Here you can see pericardial effusion and some dysfunction that's here in this case. Placental changes as well. You see calcification within the placenta. Again, you and I know that there's many reasons for changes, the calcifications within the placenta, that may not be everything that you need to recognize and to do along those ways. Here's more musculoskeletal changes, arthrogryposis. This is a case from Colombia. We've shown some of these examples before, so we won't spend a lot of time. Here's another set of examples as well. So again, is the microcephaly just the tip of the iceberg? No, I think it's the end stage of it. I think we should be able to identify and recognize some of these things long before, as we see some of these changes that we've pointed out, the eyes, the ventriculomegaly, the calcifications that we see throughout. So there were people that asked questions, does Zika really cause pregnancy problems? And the answer is all these papers that have been published have certainly linked a positive Zika flavivirus RNA found in the brain by PCR, showing and confirming that indeed these are directly related to the Zika. So in fact, there is definite proof that it can cause these changes. There are some myths. The myths reported in the New York Times that it was genetically modified mosquitoes that these caused. Engineered mosquitoes were released in Brazil that controlled dengue. That's just not true. Microcephaly outbreaks were 1,700 miles away, and mosquitoes fly less than a mile in their lifetimes, as I pointed out earlier. And only male mosquitoes were released, only females bite. You and I know that these aren't true. Was there a problem with larvicide, which many of you may have read about in drinking water? This is certainly not true. And these are all the chemical things that have been proven to be safe along the way. And maybe it's a bad batch of vaccines. And we'll come to vaccines in a few moments towards the end of the presentation, but that certainly is no vaccine that's there at all. Additional recent CDC report, and I'm not going to go over this slide in detail, but they've again proven that Zika virus has been identified in stillbirths and babies that subsequently dies, where they've identified both the antigens and the positive PCR in these cases. Here's a picture of a retina and the changes that you can see in some of these babies that have been born that have presumed congenital Zika infections. More ocular changes that are there. So there's disc hypoplasia, there's nasal atrophies, a variety of different of these lesions that have been recognized. Brazil group has been conducting surveillance for dengue in populations of Rio for many, many years. And indeed, in 2015, it was noted that an increase in dengue-like illness with a rash, coinciding with a similar surge in cases in northeast Brazil, and finally these were identified as Zika. All of these Sherlock Holmes approaches to make it have identified that it is more likely that women who are symptomatic will have babies that are infected, but it doesn't mean that the others will not, but very clearly those we most worry about it. You can find the pregnant women having the symptoms if you see someone in your office. I think the pictures in the New England Journal were spectacular, looking at the conjunctivitis that you can see, the blotching of the eye, the rash that they get throughout the body, wherever it may be, the lymphadenopathy that they may get behind the ears. All these things that we typically see with infections, but very clearly specific to a woman who has recently traveled, who have these type of rashes, we ought to be paying attention to. Or their spouses may have traveled and they may have acquired it through sex. Those are other ways that we're doing very clearly. In the other series, very clearly abnormal results seen in 29% with Zika infection. So you may not have a finding in the fetus with a positive blood test for Zika, whether it's a PCR, RNA, or whether it's IgM. These babies should be followed. You should follow them in utero, as we showed you the algorithm that I showed you earlier, and I think that's very clear what we need to do. What's the overall risk? Lancet reported maybe a 1% risk to the fetus. We think it's probably a bit higher. I think these are the things we need to think about as we accumulate registries to see how long it occurs. But I think as we create these prominent ways to look at and follow these babies, it'll be important that we don't just use assumptions, but we look at the best fit risk infection in the first trimester, which is about 1% relative risk, very clearly making a dramatic difference as well in the second trimester. But still, retrospective and stations not identified become very important for us to do. So what do you tell your pregnant patients? Despite earlier reports, the recent data suggests later gestational age infection does not exclude potential adverse effects, which I told you. There is neither a vaccine today, although we'll talk about what's being developed, or prophylactic medication. The CDC recommends that all pregnant women strongly consider postponing travel to areas with active Zika virus infection. I can't begin to tell you how often we tell our patients that. Oh, my mother says it's okay. We're just going to go for a short visit. We try very hard to encourage them not to do anything like that, not to go. As I said, this is a very important website for all of you who are listening. You should look at the CDC website. It's extremely informative. Up until last week, they had a great little app that you could text to the CDC, tell them where you're going, and they'll tell you whether Zika is endemic in that area. They have shut that down for some reason. Hopefully at a later time, if it ups its interest, they'll find it. Equally important is what do you tell your patients to do if they are going or they have to be there for work or family or whatever it may be, and that is that they need to have repellent. They need to have screens where they're staying. You know, in some of these areas in Brazil and Central and South America, Latin America, they don't have it. We encourage them to try to get it to protect themselves, but people should wear long sleeves and pants to try to restrict the chance to get bit. Safe in pregnancy, proven safe, used time and again. These patients and in adults, male as well, since Zika can affect males, particularly with Guillain-Barré syndrome, which is a catastrophic neurologic effect on an individual. By using DEET or any of the other things, the IR353, picaridin, oil of lemon eucalyptus, but DEET is the one that they should be using regularly if they happen to go to any of these areas. Now let's start looking at some of the current statistics, and I'm going to skip this slide for a second, go to some more how do we test it, and then we'll look at the current numbers as of last week. There are now commercially available diagnostic tests for Zika virus disease. Let me tell you, when this first started being reported a year ago, in the state of California, in most places, you had to go through your state health department to get it tested. You had to then have them send it to the CDC, and maybe a month or two later, and sometimes longer, you got the results. Very frustrating for many of our patients, and in that way, the great interest of some of the commercial laboratories and academic centers to develop their own testing took place. And now I tell you that for sure that some of the commercial laboratories will get this testing done, and you no longer need pre-approval like you did before. What tests should be done? Within the first week of after onset of symptoms or even travel. Testing is for Zika specific PCR on serum. Okay, PCR alone is really at this point held back for symptomatic patients, although I said to you patients want it, they typically will get it sent to the commercial laboratories. You need 2 tubes for each test, for the antibody and the PCR, and we also send urine if the patient is symptomatic. All other patients are going to get tested beyond the 2 weeks for Zika-specific IgM. And it typically doesn't develop until after a week that they have the disease. It doesn't show itself earlier than 2 weeks and no later than 12 weeks. So after 3 months, there's really not much testing you can do. Well, I was there 3 months ago. Well, not much testing you can do. If there is other antibodies that are present for the Zika, there is neutralizing antibodies that can be done, PRNT, that will cross-react between the other flavivirus that are there. Late onset microcephaly. This is a report that in last August reported seeing late onset microcephaly amongst 1,200 pregnancies in Brazilian women. I discussed this a bit earlier, that if you're infected in the 3rd trimester, these babies need to be followed by the pediatricians very closely. I participated in the WHO Emergency Committee meeting last March. I will tell you that unlike Ebola and the other things, they were very concerned about making sure that they took care of these things. They got updated briefings, and already in September of this year, they already had their 4th report of this committee. So they were really on top of these changes. So let's look at where it is before we conclude, and where it's not, and what you need to know. As of March 10th, which is 4 days ago, this is the map that you can see where you have reported active virus transmission throughout the United States, Brazil, Jamaica, all these countries, including Singapore and some in the Pacific Islands. As I said, these are all available from the website. Zika virus is considered endemic in some cases, and a large number of local residents are likely to become immune, which is an important factor for them who live there. But U.S. travelers to endemic areas may not be immune, and you need to think about what effect that they have, as we've been talking about the whole time. And here's just another update of where in the African countries they found it, in India. All of these have endemic to the Zika virus, so none of it is immune. Patients who are traveling, find out where they're going and have them check the CDC website, and perhaps not to go there if there is an endemic that is going to be taken seriously. As of March 8th, which is the last reporting, and there'll be more reporting tomorrow, there have been 5,109 cases in the United States. Travel-associated cases represented 4,800 of these. The others were other reasons for it, and the others were 45 sexually transmitted disease. And to date, there's only been 13 cases of Guillain-Barré syndrome in the Zika-affected cases. Locally acquired vector-borne cases, i.e. the vector is brought to the States and it sits dormant and all of a sudden mosquitoes come out. That's had 221 cases in the U.S. territories. There have been 147 travel-related cases, and locally acquired reported cases were 38,000, all but 1,100 in Puerto Rico with 900 in the U.S. Virgin Islands. There they had in the U.S. territories 51 cases of Guillain-Barré. 1,534 pregnant travelers with laboratory evidence were in the U.S. Majority, again, as we said, were travelers. And again, this confirms what you just saw earlier about pregnant cases in U.S. territories being very high, particularly Puerto Rico, who's had their fair share. If you look at the number of cases, the larger number of cases, there have been scattered in some of these areas, as you can see, and it's been reported in almost all states in the United States. The larger numbers occur in California, a lot of travel because of Mexico, Texas, and Florida, and Georgia has some, and obviously New York, through the cases of a lot came from Puerto Rico there. If you look at California, as of March 10th, you can see the Los Angeles County has the most, 113, surprising even more than San Diego County, which is certainly closer to Texas, to Mexico, that you have there. So these are the things that we can clearly see. In where do the patients come from? In California, you can see the majority of them were in Mexico when they obtained the Zika infection, 21 in El Salvador, 15 in Dominican Republic, 13 in Honduras. These are actually the Latin American countries where the USAID is made alert to go and visit and see how their capabilities are and how ultimately the U.S. can help them and be better equipped to handle these situations. But you can see these are largely these areas, and you can see more in Mexico by state. And if you look at some of these areas, for example, Mexico City, you do not see any in Mexico City because it's too high of an altitude. So knowing where it is, as we talked earlier, the altitude, how high north, but particularly altitude plays a very important difference. You also haven't heard as much about Zika depending on the weather. In the colder weather areas, you're not going to find mosquitoes as many places as they are there. And here again, as of February, confirmed cases in all the Mexican regions. So we discourage travel to all these areas. This is all, again, the numbers not critical, but just to show you that these are breakdowns that you can obtain from the CDC website. So again, when you look at areas above 6,500, that's the lighter ones compared to the below, you can see these are the safe travel areas. If you think about it, here's Mexico City, quite high, but no reported cases there. Local Zika transmissions in Florida and Texas certainly have occurred. As you can see, the health department response. Wynwood is an artsy area in Miami. That is where it first came, but then they found more down the beach. Zika in Brownsville, Texas. These are, again, very specific areas. They actually had spraying has occurred in these areas in Florida, but the winds on the beach seem to not have as effect as we want to. But again, if they're there, we recommend that males wear condoms for 6 months after, because it stays in the semen longer. If the male has had the exposure to the Zika, again, 6 months of condom use is recommended if they've had the travel that's there. Finally, just as a curiosity, to date, no reports confirm Zika among those who attended the games. Again, it may be the time of year that it was or the luck, but very clearly these are safety things would have those great concerns. Other things that you need to think about in OB care, organ donations, sperm donors, they should be ineligible for 6 months if they've been diagnosed with Zika virus. This is very, very important. Or if they've had sex with a male partner with either of these risks. It also applies to umbilical cord blood and placentas. We need to think about this. This has recently been updated last year and more recently. The U.S. has certainly been very strong in not allowing blood donations for at least 6 months. It's now on the question list. Did you travel? Were you exposed to the Zika virus? So again, all these ways that you can have transmission of the virus become very important as you think about the things as we do. And this is through March 8th, 39 positive donors in the U.S. were found, 318 in Puerto Rico. Very serious, very things we need to take seriously about telling our patients who are about to donate blood. What are the proposed mechanisms? Well, it's a neuroprogeny cells. It gets into the brain. This is the research that they're trying to look at for possible pharmacologic inhibition. This is some great work that's being done by basic scientists. I don't think we'll focus a lot of attention, but just to say there's a lot of work being done in that area. They're looking at early drugs to prevent it. Maybe you can take the drug ahead of time and it will prevent it even better than the DEET, so it will kill it as it goes on. Certainly very important. And certainly the virus, the vaccine, Fauci at the NICHD has been working very hard. There's been lots of money that's gone to support the development of the Zika vaccine, and the human trials have in some areas already begun, and I'm sure, we're hopeful at least, we're never sure, that within the year we will have something exciting within the vaccine, because they're talking about, as you know, fast-tracking these things, whether it's the current administration or not. Everyone recognizes the importance of trying to get a vaccine for this virus that has led to the terrible diseases. So this is the platform of looking at the animal model. Again, as I said, the NICHD is spending a lot of time, a lot of money in developing it, looking for efficacy of the plasma, urine, and where it affects once you have the virus, and can you do studies that are looking at it, and they're doing in monkeys, and hopefully we will have a very, very important way to prevent this disease, prevent the seriousness of it in the mother, more importantly, and equally important to the fetus, and certainly into males as well. These are resources available. I encourage everyone to look at the sites. I encourage everyone to pay attention to a regular update from CDC. As I said, every Wednesday we get it updated by the number of cases, but more importantly, when something comes out new, it's our responsibility to inform our patients. It's our responsibility to ask our patients the questions about how they travel. It's our responsibility to advise them not to travel to these endemic areas because of the risk to their fetus and subsequent long-term outcome. I'll be glad to answer any questions in the remaining time, and if those that have questions afterwards, I'm sure you can communicate with the AUM, and I will be glad to communicate separately beyond that time. Thank you very much.
And Dr. Platt, it looks like we have a couple. Are you able to see them in the question box?
I am seeing them. One question here is, are there any distinctive abnormalities that occur in the CNS of the fetus infected with Zika compared to changes observed in cytomegalic virus? There's far more calcifications. It looks a little bit more destructive, but in general, a lot of the things we see with the CMV are similar. Certainly the changes that we see with the cysts within the ventricular system, but we really didn't see the same extent in CMV of Microcephaly and the brain damage that has occurred in some of these cases. Whether it's immunity, whether it's because we've all been exposed to CMV, if we think about it, whether it's exposure and size of the virus, it's really hard to say. But very clearly, they're probably a bit more severe, but just got to think it may be on a continuum, and that may be there. That's important for us. I don't see any other questions there, Kathy. Okay, if someone has contracted the Zika virus while on vacation but does not become pregnant until 1 year later, do we know if the fetus will still be at risk? If it's after a year, the answer is she should be pretty safe. She should be pretty immune from it, and it shouldn't have an effect on that pregnancy. What are the effects in adult with Zika virus? The most serious one, obviously, the symptoms that you saw before, including the conjunctivitis, the effects that we see in adults. The most serious one will then be Guillain-Barré, and that has been a major issue with a lot of viruses, certainly, but the Zika, that is probably the most serious effect in adult, in males, and in women as well who are not pregnant, that you see as an effect of the Zika virus.
And I don't see any other questions at this point.
And as I said, I'd be glad to answer any questions that you may submit to the AIUM. I'll be glad to get back if you email. This is certainly an important area, and again, encourage everyone to look at the resources that the CDC has made available, ACOG, AIUM, ISWAG. Very, very important for us to think about and do our job at preventing any serious consequences. And avoidance may be the most important way to think about it.
Great. And it looks like we do have a couple more, but since we are out of time, I will send those to you, Dr. Platt, and then perhaps we can get the messages out to the people who are asking the questions.
I thank you for your attention, and it's been a pleasure to present to you this evening.
And our thanks very much to you, Dr. Platt, and our thanks to everyone who participated tonight. Everyone, please remember to complete the post-test and the activity evaluation. We hope you enjoyed tonight's presentation and will join us again for future webinars. Good night, everyone.
Good night.